OK，谢谢大家。我叫做天才 ，You can call me 天才，天才 Joe or Professor Joe. So thank you so much for the invitation. Take it, 谢谢 Tina, yeah, Prof.Dr.Med for the invitations. I'm talking about the tips and tricks in reverse shoulder arthroplasty. These are my five fellows. Yeah, they are very active, and 2 of them is here. One from Philippines, one from Thailand. So this is the pictures of today. Very nice group picture. And 谢谢 professors for coming to Thailand and sharing your experience. Yeah, this is your picture. Snapshot. Yes, and Tina, thank you so much. 谢谢你. So we went to the COA meeting last time in Wuhan. You were there in Wuhan. Yeah, many of them were there. So Thailand is like a guest nation at that time. So we are very proud, and thank you so much for taking care of us, and I have a chance to make a workshop of the similar development in the COA meeting at that time. Yeah. So we are sharing how to do the fixation. So we are talking about the reverse in massive rotator cuff tear. I will focus in techniques. So this is very typical patients. In Thailand, we use 70 years old. I'm not sure in China what is your age for the reverse. In China, in the patients 65, yeah, 65. So in Thailand, we mostly they accept at 70 years that we do the reverse. This patient, she has a pseudoparalysis and torn all the rotator cuff. Sorry. Yeah, so I use deltopectoral approach. So some surgeons in Europe, they like to go deltoid split, but I think most of you use deltopectoral approach, right? Same, yeah. So we identify the septic vein, retract to the lateral side, okay, and then we slowly release the subscapularis. Okay, and then I will set my subscapularis slowly and make it nicely, and then dislocate. Okay, so the next thing is that you need to make a good exposure and find the center of the head. So I always divide the head into 2 parts equally, right? And then I put the stem in. I use the native version. This one, I use the arm position and make it parallel to the arm, right? So each patient is different. And then I protect my humerus with the protector, expose the glenoid. I think this is the key. Everyone, you need to have very good exposure of the glenoid, and you put the glenoid lower, okay, flush to the 6 o'clock position, make sure, okay, because if you put it too high, your problem is that you will have the notching. And I always put the bone graft on my glenoid like that and use the glenoid bedspread. Mostly in our Asian side, we use the smaller size. I think the same in China, right? Use 25 millimeters, and you have 28, right? 28 also, but mostly we use the smaller size, yeah. And mostly I use only 3 screws. I use central screw, 12 o'clock and 6 o'clock most of the time, right? And you put the glenoid bedspread, the gynosphere. For the humeral side, I make a loop like this, so this will be stable, and put my stem. I rarely put the cement. I don't like cement, yeah. And when you have a gap here, you should put the bone graft on the medial side. That will make your stem valgus, okay? If you don't put it like this, your stem will go villus. We don't like villus, we like valgus, okay? And I always put my stem a little bit 1 millimeter smaller than the trial, okay? And when you put the bone graft, it will be very fit, okay? And most of the time I use an offset, okay? +3 or +6 most of the time, because I like to not too much lateralize, so I can repair my subscap back after the surgery, okay, like that. And set the tension, check the length of motion, okay? So always check your subscap. Your subscap can be pulled to the lesser tuberosity. You should need a lot of release. Make sure that your subscap is mobile. If not, you cut the subscap from the coracoid, from the rotator interval, okay, to make it mobile. I think this is important. And the way we repair the subscap, we repair it like suture bridge. Okay, I show you. We call the suture bridge technique. Yeah, using transoceous. So finally, you have like this, right? And check the stability. You should go external rotation at least 45 degrees. That means you are not too stiff. Okay. Yeah, and check your cephalic vein again here. Many times there's some bleeding in cephalic vein. So stop the bleeding first. Yeah. So that is the technique of my reverse in the contact arthroplasty CTA. Yeah. And we put the patient in abduction brace at the beginning because if you put it like this, there'll be too much tension. And sometimes if the patient have weak bone, they will have fracture of the acromion. So better put the abduction brace after the surgery. Okay. So this is about 3 months. The patient happy. She can live up and she has a good range of motion after surgery. So the second one, this is a very active golfer, 70 years. So he have the severe proximal migration. You look at the Couturier, yeah, this is very bad. He has good subscap, bad supraspinatus, bad infra, but good teres minor. So this is a good candidate to do reverse. Okay, so we have good deltoid, good subscap, good teres minor. These 3 things that you need for your reverse. Yeah. So always check first, right? So before surgery, patient have the pseudoparalysis, okay, and also weak axial rotation, but good subscapularis, okay, before the surgery. So we did the same, and always I pack bone graft, okay, on the middle side, okay, and check the subscap. I always release subscap and repair the subscap back. Is it possible, right? So for me, I don't like to go too much lateralization. I'm not sure how about yours idea. I don't like to go, I do lateralization, but not too much. Okay. So if you put it too much lateralization, you cannot repair the subscap back. Yeah. So this is the X-ray after surgery. You can see our prosthesis. I always put it lower to prevent the notching, and also lateralization is about 1 centimeter. Okay, and the patient happy and have good motions, and also he want to go back to golf again, right? So now he's happy to play golf again. Do you allow your patient to play golf? Huh? Yes or no? Huh? No. Your patient don't like golf, but mostly it's women, right? But he's good. He said he's out there. His life come back. He's happy, yeah, to play golf again. So sometimes you have loss of tissues, maybe especially in teres minor, you need to do some tendon transfer, right? Like LDTM, right, for the reverse. So for me, number 1, very important, you need to have good glenoid exposure. Very important. You need to have a good release. Make sure you release circumferential release, especially at 6 o'clock. You need to make good release. If you did not release well here, you may have notching, right? Keep in mind, 6 o'clock is very important. And you should have overhanging, okay, about 3 to 4 millimeter. You should have inferior tilting, okay, about 10 degree, okay, and also proper gynosphere size, right? So we prefer, in our Asian side, mostly I use 36, yeah, 36. And we put it overhanging, but not too much, okay? So this is the things that you need to be careful, right? But right now we can make the skin smaller. Yeah, you see, you can make it smaller because like you do minimally invasive surgery, you can make it smaller. You see the wound, the mouth, yeah, it's the same size, like the smile, okay, same size, yes. So patient happy, and very important thing for the humerus side. we put it valgus stem. Yeah. So always put the bone graft. I put it like when you trial number 10, I will go back to number 9. Okay, because once I put the bone graft, it will be very fit. Yeah. So I put it one size smaller because I will pack the bone graft. Once you pack the bone graft, you can see that your stem will be valgus. Okay, and this packing will make metaphyseal fit. When you have metaphyseal fit, it's not the diaphyseal fit. I don't like to fit here. I don't like it. This to fit is not good because you can create a fracture in the future with stabilizer. So I like to make it fit on the proximal. Okay, and also we pack the bone graft that will promote the healing and make the stem valgus. Okay, and also I will pack the bone graft at the tuberosity also, right? That will prevent the GT fracture and also the resorption. So now I'm sharing you my technique about the subscapularis. So I always put the suture into the canal like this and make a loop. Because when you put the stem in, the suture cannot cut out. It was fixed by the stem because it loop around like this, it's locked. Yeah. So that will improve the stability, improve the internal rotation, and also increase external rotation sometimes. Yeah. So I repair the subscap always when we use the medialized system, right? Previously, the Johnson & Johnson, they use this medialized system, you need to repair. That will improve the stability. But right now, mostly we use the Bancha. This is the lateralized prosthesis. So if you cannot repair it, I mean, if it's too much tension, like in fracture sequelae, like in the revision surgery, you don't need to repair it. Okay? But is it repairable? I prefer to repair it. Yeah. So this is the way I repair it. You look at the diagram, right? I make the holes in the humerus. Okay, we have 2, 1, 2, 2, 1, 2. Okay, and then when you tie it, it becomes like E and X. This is E and it's X. Okay, so it's like suture bridge. So good thing is that your subscap will have good compression like you do the rotator cuff repair. Okay, very easy. Now I show you the techniques. So first I drill the holes here, 1, 2, 3. Okay, we make 3 holes medial to the lesser tuberosity and make 3 holes lateral to the lesser tuberosity, and then you put 2. Okay, this one is 1, and this one is 2. 2, 1, 2. Okay, so after that you put the stem in the middle, and then you pull, right, and then pack the bone graft. Okay, make sure that your subscap is freely movable. Yeah. Okay, and repair the subscap back. So you can test the subscap mobility by pulling. If you can pull the subscap to the lesser tuberosity without tension, that means it's good. Yeah. And check the range of motion after the surgery. The patient must have good external rotation without tension. Okay. So this is the E. Okay, you repair the E first, and then you cross E, you become X. Yeah. So that is a very good repairing of the subscap. So the tension will not too much. Okay. This is X, like this. E and X. Okay. So check the motion. You see, external rotation to 45 without tension. Okay. So for fracture humerus, yeah, I saw many of you. You have a lot of experience. You have very bad case in China because your population is so big. So it's very interesting. So for the fracture case, I prefer to use cementless because I found a lot of patients use, a lot of surgeons use cemented, and it's very difficult to revision. So in practice, I try not to put the cement. Yeah. So the CTA, I think 0%, never put cement. For fracture case, I put cement about 10% mostly. Yeah. But very few. I try not to put the cement because you know the cement from the literature, they found that the cement, they tend to have osteolysis, and also the anatomic tuberosity healing is less, yeah, comparing to the cementless. Yeah. And this is a complication of the cement. You may have thermal damage. You may have the cement implantation syndrome. You may have increased the operation charm and difficult for the revision surgery. Yeah. So the good thing of cementless is shorter operative time, decrease of the intra vein thromboembolism, and improve biologic fixation, and easier for revision. Okay. So this is a video from the meeting. Yeah. Thank you, Dr. San and Tina, for helping me making this demonstration. So I show you in model, that will be easier, right? So first thing is that you identify the bicipital groove when you dealing with a fracture case. So I always break my bicipital groove and make it like open book. Okay. So and then you cut the rotator interval. You need to cut it so it's become like this. Open the book. Okay. And then I suture the suture to the tuberosity like this at the bone tendon junction. So we put it about 4 sutures here on the tuberosity. Okay. And lesser tuberosity, we put just 1 suture, and then you can expose the glenoid very easy. And then you draw the line of the from 12 o'clock to 6 o'clock. Yeah. Okay. Draw the center. And this is wrong. You should put it lower like this. Yeah. 5 8 6 o'clock position. This one is the new design of the glenoid base plate. It's the augmented base plate, right? 10-degree tilt. So after you put it, then you can test again. Then you put another pin. Yeah. So this can help you to read the proximal part. Okay, and you can put this in. So now it's launched in China, right? This one. Already, right? Yeah. Yeah. 1 year now. Yeah. This is the new one that we call the augmented base plate. Yeah. And then you can read the proximal part like that. Yeah. Remove the cartilage. Okay. And then you take this out. Yeah, take this out. So if you use a conventional one, I always put some wood graft on the top because you will have some gap. But if you use this augmented base plate, you will have no gap on the top. Okay. So you see that the upper part is thicker. Yeah, and this there's a peg here you can guide you in this way. This is the good things of the augmented base plate, 10-degree, right? So when you put the base plate in, you see it flush very well, perfect. Yeah, there will be no gap on the top. Otherwise, you need to ream too much to the medial side. I don't like that. You ream too much. Yeah, and then we fix 3 screws. Okay. So after fixation, yeah, 1, 2, 3. The upper screw, I always put this to the base of coracoid, the upper one. Yeah. So then we put the gynosphere in. For me, mostly I put it B. I don't like to do too much overhand. I like B. Yeah. Because I can increase my polyethylene thickness. So yeah, after that we put the gynosphere in. Yes. And now, I think for the fracture case, glenoid is easy. The difficulty is on the humeral side, right? Humeral side. So now I've drilled 3 holes, 1, 2, 3 for my humeral side like this, and make a loop like this. Yeah. So you put the stem in. Most of the time, I did not use the fracture stem. I use the conventional stem, and look at the versions. Okay. And then you check the calca. Mostly the calca is still there. My prosthesis will sit on the calca. Okay. And reduce it back. So the suture that you repair will go around. You see, it's go around this way, allow the prosthesis, okay, to the medial side. Okay, because you already repaired the greater, then you repair the suture to the lesser. So this suture will move around your prosthesis. I don't like to go to the prosthesis. I like to go around. Yeah, like this. So once you wrap it around, then you can make the circlage, okay, of the fixation, like that. Okay. This is the circumferential. So after you have circumferential, we put it about 4 most of the time. 4 circumferential. And then we follow by the vertical suture. Will be like figure of 8. Okay, like this. So your suture will, from the shaft, you go to the infraspinatus to the subscapularis. So this becomes the vertical suture. Okay. So you see that you go around and then you have the vertical suture. Okay, this vertical suture will stabilize your prosthesis, the humerus to the shaft. Okay, that will be stable. And don't forget to put the bone graft. Bone graft important. You should fill the gap with the bone graft a lot. This bone graft will promote the healing of your tuberosity. Okay. So okay, example, she is 72 years old, 4 part fractures, very bad. And the BMD is just minus less than 2.5, very bad. So the deltopectoral approach. First, I always break my lesser tuberosity, break it, yeah, and then take the head out. Okay, cleaning, remove the communal. That is the greater tuberosity, lesser tuberosity. It's like open book, yeah. And then you slowly put the stem in. Okay, clean the glenoid. Glenoid is easy because in fracture the proximal have a big gap, so it's easy for you to manage the glenoid. Yeah. So after that you rim in. Yeah, I will not rim too much because you will be too much medialization. Okay. Okay. After that we pick the screw, center screw, and 6 o'clock and 12 o'clock screw. Next step is to fix the tuberosity, right? After the preparations, then I put my stem in. Yeah. So you at the CT scan, you can see that the calca is always flush to the prosthesis. Yeah. But if you have comminuted on the medial side, you can calculate how much you need to put the graft. Okay, then we drill on the proximal. 3 holes. So this hole will be 2 sutures and suture around. This one we use the cement. Yeah. Okay. But actually right now we use less cement. Okay, put this in. And then reductions. Yeah, so you see that. Then you put the bone graft around here. Okay, reduction. Trial. So sometimes it's very tight. I will pull the humerus, and I see my prosthesis is about half of the glenoid. Okay, because sometimes when you reduce, it's difficult to take out. So I will not trial. Okay, I pull, and I feel like this is good. Then I will not trial, and then you make a cerclage and vertical sutures. Right? I show you in the sawbone. Right. Okay. So, like that. Fixations, circumferential vertical fibers. Okay, very fast surgery. Okay. Yes. Okay. And the bicep here, I always repair my bicep back to the conjoint tendon like this. I repair my bicep side to side to the conjoint tendon. This is the way I do bicep tenodesis. Very easy and very reliable. Okay. So this is after the surgery. They have a very nice tuberosity, fixations, okay, good strength and good motion after that. Okay. So this is another patient. They are severe osteoporosis, 4-part fracture also. Okay. So that is the reductions. I use the conventional stem. I did not use the fracture stem. Use conventional stem, right? Same like the previous patients. Fixations and tuberosity fixation. I think the very important is that the tuberosity mobilization and fixation. That is the key in fracture fixation. Because if you have good tuberosity healing, the outcome is always good. Yeah. If you have bad tuberosity, you have big body defect. Finally, the shoulder will be unstable and the stem will be loose. Yeah. So you see this is after the 9 months is completely healed and the patient have good range of motion. Okay. Yeah, she's very skinny and very osteoporotic. Yeah. Yeah, external rotation is not bad. You see, it's better. This one in the surgery is better than this one. Because this one she has also tried this also. So this is a difficult case. The non-union. Yeah. So you should not take this out. You should keep it. This piece, I will break it. I remove the cartilage, but I will save the tuberosity. Okay. So this is very common. The non-union. This patient have 10 years of the pseudoparalysis. Yeah. She's weak. Yeah. Yeah. And subscap is not bad. Yeah. So we do the surgery. Okay, same the two pectoral. But once you get in as a biceps, I cut the bicep. I break the tuberosity. You see that? This is very important because like you open the book. Okay, you make it like 4 parts. Even it's 2 parts, you need to make it 4 parts. Okay, break the tuberosity. You keep the lesser tuberosity with bone, like that. Okay, and this is scattered tuberosity, and you remove the head. That's a glenoid. Glenoid is easy, right? So cleaning the glenoid. When you finish the glenoid, then you come back to the tuberosity. Yeah, like that. Infiltrate. Okay. Glenoid is easy. Then we come back to the humerus, right? This humerus is a very big defect, right? You can use the allograft, you see? There's a big defect here. That's nothing. So if you put the stem in like this, it will lose very fast. So the key is that you need to save the patient tuberosity. Okay, this is like that. Put this in. Yes. Okay. Pack the bone graft. Reduction. Okay, reduction, and then same like you do 4-part fracture. Okay, put the bone graft. This is important. I need to pack a lot of bone graft because this patient have the non-union long term. Yeah. Then you make a circumferential like this. Repair the subscap to the gator tuberosity. Like that. Yeah. And save it like that. Okay, that's a vertical. Yeah. Put the bone graft. Okay. You should have no gap between the tuberosity. Okay. And that is X-ray. And this X-ray, it look okay. This tuberosity finally is healed, right, to the head, and the patient have the good range of motions. Yeah, after surgery. Yeah. So it's quite happy. Yeah. So neglected dislocation. This is a posterior neglected dislocation. Okay, very bad, and we can fix it back. We have a lot of neglected dislocation. This is the posterior. This is the anterior dislocation. 10 years of dislocation, unbelievable. 10 years, you see the deformity. It's so bad. She cannot elevate. She cannot external rotate. It was 10 years. Very difficult. That's a very big bone defect in the front. You see here. So the CT scan, you see, there's a big defect in the front. Right? And this CT scan, then we can save her shoulders. Very tight, I need to recut again. So, yeah, pack the bone graft. Very tight because the dislocation is too long. Yeah. Need to shorten a little bit. Okay, reductions. But this patient, I cannot repair the subscap back. Yeah. So we have. So for the osteoarthritis, okay. So osteoarthritis, it's in the past we did it anatomic replacement, but nowadays in the patient that very old, like 80 years old, most of them have bad rotator cuff. Okay. So every time I need to check the rotator cuff with MRI. You see, this patient, if you do anatomic replacement, the patient will have bad outcome. So always check the MRI, not just the CT scan. Always check both. If the patient have arthritis in elderly, so his back supraspinatus and lateral version is 13 degrees, right? So we decide to do the reverse for her. So in arthritis, you need to expose the 6 o'clock very well, because this is important. If you did not expose well, this part will impinge and cause the notching. Yeah. So you need to expose 6 o'clock. They are also fight very well. Yeah. And always we keep the same version. Okay. So I skip this, pack the bone graft, the same like we do, right? The key point. Another thing is that in arthritis, I always release supraspinatus. I'm not sure in your practice you release or not. Prof, you release supraspinatus or not in arthritis? Reverse in arthritis. Yeah. How about you? You release or not? The supraspinatus. Yeah. Because I have one patient, I did not release supraspinatus, and I do dislocate, external like this. The rotator cuff pull the tuberosity, and it gets broken. Yeah, because in reverse, when you put the glenosphere in, right, there will be a lot of tension when you external rotate. Okay, when you external rotate, the greater tuberosity will be pulled by the supraspinatus. So if you not release that, the patient would have a fracture of the tuberosity. And if you do reverse, I think the patient don't need supraspinatus anymore. Yeah. So this is the reverse. Make sure that you clean this very well, right? Otherwise, this part will impinge and you can cause the notching after the surgery. This is only 59 years old. Yeah. Also try this. But you see that the head is medialized. Once you have the arthritis and the head is moving to the medial side, that means the bone loss is a lot. Yeah, always. So you need CT scan every time in arthritis. Make sure that you see that this is the glenoid is so bad, 30-degree lateral version. Okay, rotator cuff is good, but lateral version is too bad. If you do anatomic shoulder replacement, the glenoid will lose very fast. So the acceptable angle is about 15 degrees. So it's more than 15 degrees, like 30 degrees, that's too much for anatomic shoulder replacement. So I discussed with the patient that I will do this or do this. What do you think? This one or this one? Also try this. X-ray look like this. Rotator cuff is good. A or B? A. A. B. Yeah, everyone B. Very good. Because if you do A, the glenoid is difficult. It's too much lateral version. Once you put it in, it gets loose. Even you put the bone graft, it will be fail, right? So I think for the glenoid that is very a lot of bone loss. More than 15 degrees, I prefer to do reverse. Okay, so I do reverse for him. This is Chris' sister. Okay, release and yeah. Okay, so glenoid component. You see, the glenoid is very bad, very bad. You see. So we need to add some bone graft and the glenoid limbing because severe lateral version. Yeah. Okay, here. Dealing, and then we put the bone graft on the back here a lot, yeah, and pack the bone graft. Okay. Okay. Also at the tuber side, we pack it. Yes, and we pack the subscap back. Okay, after surgery. So the patient doing well. So for the arthritis, I think number one is that you need to have good exposure and identify the goat beard. This also fight. Okay. So the way to expose this goat beard is that you elevation and slowly external rotation. Remove the ossophyte, release the inferior capsule, take this out. And I like to release supraspinatus to avoid gator tuberosity avulsion fracture during the dislocation or during the reduction. Okay. So this last patient is prosthetic infection, right? So this is a very bad situation. We need to do the debridement, antibiotics, CT scan, and have a good design. You need the patient-specific instrumentation. So for the very difficult case or revision surgery or big cranial bone loss, I need this patient-specific instrumentation. Yeah. But the PSI from Sigma is a bit too far from here. So we have the in-house PSI. Okay. So in summary, for the technique of the reverse shoulder arthroplasty, number one, you need to have good exposure, both glenoid and humeral side. Okay, focus in glenoid. Yeah, and you need to have overhang 4 millimeters. You need inferior tilt because these two things will prevent the dislocation and also the notching. And you need lateralization, but not too much. Okay, and proper size. Yeah. So for the humeral side, I prefer Walker stem. I put the stems one size smaller, pack bone graft, metaphyseal fit to get this impact, right? And always put the bone graft to promote the healing. Yeah. So that is a summary. Yeah. So this year we will have the meeting with China. I would like to invite Chinese friends to Thailand. Because our Royal College Orthopedic Surgeons and COA and HKOA, China is our guest nation this year. Okay, so we have workshop. Yeah, in this meeting also. This is the kind of workshop on the beach, by the beach. Okay, we have the shoulder workshop. We have trauma workshop. We have robotic workshop. 3 workshops. Okay, on the beach near the sea. Yeah, not in the lab. Close to in the hotel. Yeah. So not softball is cadaveric workshop. Yeah, same like you do in Srila Hospital tomorrow. And also, yeah, we have this is our president, yeah, Professor Kilati, and this is the tourism that we promote. Okay, so it will happen in October, right? It's October. The workshop is on the 22nd. Okay, so 3 workshops. I will share you information. This is Pattaya, very beautiful. Come back to Pattaya again because now we have no visa. We are visa free now. Yeah. So there's Zhang Yingzhe, the president, yeah, Dr. Wang, and this is from Hong Kong, Dr. KK and YK, right? And this is the QR code. Take a picture. Please take a picture, everyone. So if you have no time, you can see this later. Okay. So this is the workshop. Yeah. And this limited seat. Would like to have you all coming to Thailand again. Okay. And that is my WeChat. Yeah, we can be friends. Please add my WeChat to be your friends. OK， 谢谢你们，谢谢大家。Yes, any questions? Yes, please.
For like the biomet only design, usually the repair of the subscap is very difficult. So how do you define a repairable subscap?
Yes. So first thing is that it's always if you did not release it, it's will be difficult. First, I will cut my subscap from my supraspinatus through the rotator interval. I cut it this way to the glenoid, okay? And then I cut my subscap from coracoid. That will be coracoid humeral ligament. So you cut it like this, cut it like this. So that will be like L shape. And then you can release it, use your finger to feel is that any tight. Then most of the time we can release that and the patient have not too much tension. So key is that cut it from supraspinatus, cut it from the interval, cut it from the coracoid, yeah, and release it using a cautery from the glenoid. And you should not over lateralization, not over. So I read my humerus, and I always on the humeral side, I prefer to use the offset 3 or 6. Yeah. So we use offset, your lateralization will not too much. Okay, and that will fit very well to your humeral surface. Because most of the time the stem will locate it more medial. When I pack it in, it will locate more medial. If you use a conventional one, it will be overhang and impinge. So better use the offset. Yeah. So release and use offset.
So when you repair the subscap, will external rotation
45 degrees.
45 degrees.
Yes.
So if you cannot reach the lateral tuberosity in 45 degrees,
no, I don't repair. I don't repair. Yeah.
Okay, thank you.
Because if you repair, I found one patient doing the surgery from another hospital. Post-op the patient is like this. He cannot exrotate at all. Yeah. So release and make sure that you pull the tendon. If you feel the tendon can go to the lesser tuberosity, that means it's good. Yeah.
So another question is about the drug fit fixation.
Yes.
Especially in fracture patients.
Yes.
Yeah, because
so that's challenging.
Yeah, in very elderly patients, the proximal bone is very bad.
Yeah.
Only very thin. Coastal bone. So
right.
How to
So we use this way, the 3-point fixation, like I show you. We pack the bone graft a lot, okay? And maybe you can use the longer stem to fit distal, okay? So I try not to put cement because sometimes we need to come back for revision if there's cement inside, it's not easy. So pack bone graft and you can use longer stem. Yeah.
Okay.
Thank you.
是你的翻译刚刚对对。
Okay, I translate to my Chinese colleague.
Yes.
就是两个问题，一个是肩胛下肌，它是因为这种假体期肩胛下肌有时候很难修，就是怎么定义是不是能修复？就是他说的一个是彻底松解，松解是当然两部分哈，其实主要就是说你要把肩胛下肌和就把间隙一块给它分开，然后把跟会凸的连接跟掌肌的连接都分开之后。你这个拽的时候，它比较有弹性，这其实处理到位了。然后呢，就是它呢，就是尽量是让这个假体呢稍微有点外翻，这样的话能减少肱骨头的外移，相当于就拉近了缝合的距离。另外呢，就是它就要在这个就外旋45度位左右的时候，就是外旋位，然后如果它能缝得上，它就会缝；如果外旋到45度左右它缝不上了，它也就不缝了。然后第二个问题就是说，它大部分都是生物性固定的话，就是骨折的类型的话，生物性固定它一般就是就是趋向于选择生物性固定，但它用长柄一个，第二就是髓腔里的贴点松弛骨，然后做一个打压的这个效果。但是我觉得这个还是挺有困难的。But I think systematics is very difficult in fracture type.
Yeah, I agree.
Maybe we can use 怎么说呢？就是说这个
So in fracture, I did not use a fracture stem because fracture stem is very slim. So when you put fracture stem, you always need cement. I use conventional stem. I use like a CTA stem, okay? Because fracture stem is too slim, and in Thailand, fracture stem is more expensive. I'm not sure in China, but in our country, so we use a conventional stem, and we pack a lot of bone graft. And I have a good outcome because I found some osteolysis if we use the cement. And in the literature, they also mentioned if you use cement, you have more chance of tuberosity resorption and also lysis, comparing to cementless. Okay. I always discuss with Chunyan Jiang. You don't like me, he said, no, I use cement. Chunyan from Beijing.
So another question.
Jiao Chunyan.
Yeah, in French, when you reconstruct the tuberosities, would you release the supraspinatus tendon?
When?
You tuberosity reconstruction, you will release the supraspinatus tendon.
I release it in osteoarthritis. In osteoarthritis. Because if the patient has very poor bone, once you dislocate the humerus, you put the glenosphere, okay, and then you dislocate. At that moment, the tuberosity will be broken because it's too much tension. Now you have the glenosphere is there, right? Your humerus will be here. So when you external rotate, it will be broken. Yeah, I have 3 patients broken, so I know the solution is release supraspinatus, not infra, just supra. You need infra, you need teres minor, you need subscap, but you don't need supraspinatus anymore. You can cut it.
Yeah. 他说那个就是松解的时候，他就是先松解，他就怕那个冈上肌就是对他有容易引起结节骨折嘛，就是转的时候嘛，就是要松解。其实我想问他的是那个大小结节重建的时候，是不是要把冈上肌切掉？应该是切掉了。你可以问一下。
你能帮我翻译吗？为什么对第一个问题感兴趣呢？因为在我所经历的大约有7例左右的罕见置换中，最难暴露的就是五行关节炎的暴露。五行关节炎僵硬的时候，根本显露出来太困难了，病人就是胃和活动度本身很少，所以说我那一例就遇到了一例肩胛下肌一个问题，很紧张，与暴露也很难。当时我不是已经采用了，就是说。股骨侧多节骨，肩胛下肌的就是说关节囊啊，甚至像他最初讲的从背部下说 L 型的切骨那些，把它们连都拉得开，那工作都做了，最后就是说修复的时候也是很困难，在内旋位勉强就修上。这个问题，刚才他讲到了一个在五行关节炎，说就是说一个技巧的讲，能不能让这个问题展开讲一讲？其实如果是这个问题解决了以后，其他的暴露可能都没问题了。问题就是说五行关节炎就是说一个显露的一个技巧问题，以及肩胛下肌的作用。
Okay. He asked about the exposure of the especially for the patient so severe arthritis.
Yes.
The arthritis is very tight. So
yeah.
Do you have any tips to better release or exposure?
Yeah. So once osteoarthritis, the key is that you slowly release the supraspinatus and then you elevate and X rotation like this. Yeah. So once you elevate, the release, the tension of the capsule will be less. So you should not go this way. You should elevate. Okay. When you elevate, put the hormone in and always release from the bone. Yeah. Because if you coming from outside, it's too dangerous. You release from the bone slowly, close to the bone, like I show you. Okay. And once you release, you see the osteophyte, you can break it. You use the chisel, break it. And then you have better exposure and slowly release. Yeah. So I think very important because sometimes the osteophyte is going down like very big like this, very big. So you need to take all the osteophyte. Otherwise, you will have some bone that may impinge after the surgery. You can get notching. Right? So a bit challenging, yeah, for the osteoarthritis. Better release, and then you will have good exposure of the glenoid. Yeah, if you have a good release of the humeral side, when you go to the glenoid, it will be easier. Yeah. So be patient, slowly.
他说的就是这样，就是说进去之后呢，先把冈上肌切掉，切掉之后呢，其实就是切掉之后呢，其实肱骨尽量可以往上方推一推， 这样的话会减少下方关节囊和肩胛肌的张力，然后就贴着骨就把肩胛肌松开，然后一边贴，其实就是一边贴着松解的，一边逐渐做外旋，然后露出的骨柱呢就一块就切掉，这样的话就显得会有点好。其实这种松解，这块不难，就是你一边贴肩胛肌的时候一边外旋，然后把骨块切掉。如果还紧的话呢，第一个你问问你麻醉师的肌松是不是不太行，可以改善一下。另外就是说那个可以往下沿着肱骨头下方把那个一部分的胸大肌和背阔肌的这部分可以也给它松解一部分，然后再举外旋把关节囊再松掉。一般来说这种小步没问题，这个可以想出来。
So I have the details in YouTube. I have the YouTube channel. You type BANCHA YouTube. Then you can go to my channel, and all the video is in the YouTube channel for teaching. Yeah. So you have question, you can go to YouTube. Yeah. So many, I think hundreds of the shoulder replacement in the YouTube in my channel. Yeah.
We can check your YouTube.
Yes.
It's weekend. It's weekend. So when we go back,
in China, you need to use VPN.
问陈主任，就是说松解完那个胸大肌之后还缝回来吗？
So my 三倍 online
另外还是有个肩胛下肌的
感觉，
就是说，因为我们也做运医，有的时候我们会遇到那肩胛下肌啊，就已经成那种马尾状，不知道能解决？就不用修了嘛，就。你帮我。那另外，如果咱做运医的话，咱还处理，就是肩胛下肌，它没断，它还在小结节上老实在待着呢，就是一些马尾外伤。你说上边一部分，对，上边大概有1/3左右啊，1/3左右，就是不让那个会头为止的。
So, Professor, do you also do arthroscopy?
Yeah, I do a lot.
Okay. His question is about the subscap. It's very the upper third partial tear, like the horsetail, delaminated.
The first one.
Yes. Do you repair or treatment?
It depends if the patient is young and active, I do repair. But if the patient is very old, I did not repair the first one. Yeah.
年轻的哈，就是年轻的就修，年轻的运动需求高的修，如老年人的话。
Yeah, but the problem is the subscap and the bicep. Look at the bicep. Sometimes the pain is coming from biceps. Yeah, because subscap bicep always together. Yeah.
其实就是简单的那种分层的话，就是他有人就是用那个 PS 线给它水平给它捆扎一种方法。其实刚才他说那个白菜就有好多常见一个问题，其实您可以把白菜指甲固定一下，把它拉到内侧给它加强一下也可以。
扎一下。
对，但咱说的这种都是你可能是那种撕裂比说这个要重。
对，就是其实有麻，但是它更老可能白的，这时候就是烧断了以后是，
这种应该比较少见，我觉得你
遇到
这种少见，这种少见。
当时你那个要马尾状，你最后装假体了，还在那儿看到他这个说改，我这改关键镜，不会的，你假体拉长以后，再下就回缩了，
上下飞机不管它，不管它。
Yes, thank you. I like shoulder arthroscopy. Too. We did a lot. Mostly we do arthroscope.
So you practice in public hospital or both in public and private?
I work in the university hospital, Thammasat University Hospital, and I do part time in private hospital too. In Thailand, we can work both sides, government and also private. But private, you can do it after office hours, like you do it on Sunday, Saturday, or early morning, late evening. Okay. Yes. Yeah, 谢谢大家. Thank you for the questions.